Hey everyone, Dr. Elowin here. I need to have a really important conversation with you today. One that might actually save your life, or at the very least, save you from making a decision you'll regret. Every single week, I have patients walking into my office asking about Ozempic, Wegovy, Mounjaro. They've seen their friends lose weight, they've watched the news stories, their neighbors are suddenly fitting into clothes they haven't worn in 20 years, and they want in. Here's the thing, I get it, I really do. These medications are genuinely exciting. As a physician, I've watched them transform the lives of some of my patients. Better blood sugar control, significant weight loss, reduced risk of heart attacks and strokes. But here's what keeps me up at night. The conversation around these drugs has gotten way too simple. Pop a shot once a week, watch the pounds melt away. Done and done, right? Not so fast, especially if you're over 65. See, what the commercials don't tell you, what the breathless news reports skip over, is that these medications behave very differently in older bodies. And some of those differences could seriously impact your health, your independence, and your quality of life for years to come. Now, I want to be completely upfront with you. Everything I'm sharing today comes from peer-reviewed medical research, clinical guidelines, and expert opinions from geriatricians and endocrinologists. But this video is educational content. It's not a substitute for sitting down with your own doctor who knows your medical history inside and out. Got it? Good. Let's dig in. First, some context. The obesity rates among adults over 60 have hit 41.5% according to the CDC. Nearly 30% of folks over 65 have diabetes, mostly type 2, so it makes total sense that older adults are interested in these medications. But here's what bothers me as a physician. Most of the clinical trials for these drugs had very few participants over age 65. Even fewer were over 70. Dr. Bhavani Nadaswaran from UCI Health points this out regularly. She notes that study participants over age 65 did show benefits, but there just weren't enough of them to really understand the full picture. So we're prescribing these medications to millions of older adults based on data primarily collected from younger people. That's a problem. Let me tell you what we do know about older bodies. When you're 35 or 45 and you lose weight, your body is resilient. You lose some fat, maybe a little muscle, but you bounce back. Your bones stay strong. Your muscles recover with a little effort. At 65 or 75, the game changes completely. Dr. John Batsis from the University of North Carolina has been sounding the alarm on this. He specializes in obesity and physical function in older adults, and he's been very clear about the risks. He explains that both muscle mass and strength impact muscle quality, which is key to ensuring individuals can conduct their daily activities. Losing muscle mass and strength can lead to sarcopenia, which increases the risk for functional decline, disability, nursing home placement, and death. I want you to really hear those last words. Nursing home placement, death. Those aren't scare tactics. Those are the clinical realities that I think about every time an older patient asks me about these medications. Now, does this mean seniors shouldn't consider GLP-1 medications? Absolutely not. Some of my older patients have had tremendous success with them, but it does mean we need to have a much more nuanced conversation than what you're getting from social media, or even from some busy doctors who only have 15 minutes with you. A study looking at weight loss found that anywhere from 15 to 60% of the weight people lose on these medications comes from lean mass. That's muscle. The stuff that keeps you upright, keeps you walking, keeps you living independently. Dr. Nadaswaran puts it plainly. People naturally lose up to 10% of their muscle mass between ages 60 and 70. When older people also lose weight rapidly, their muscle loss can be very rapid, causing them to become frail and putting them at risk for falls and fragility fractures. Falls, fractures, frailty. I see the aftermath of these in my practice constantly. A broken hip at 75 isn't the same as a broken hip at 45. It can be life-altering, sometimes life-ending. So before you decide whether these medications are right for you, we need to have a complete honest conversation about what the science actually shows for people in your age group. That's exactly what I'm going to do in this video. All 8 parts of it. Stick with me. All right, let's get into the science. Don't worry, I'll make this painless. But understanding how these medications work is crucial to understanding why they affect older bodies differently. GLP-1 stands for glucagon-like peptide 1. Your body naturally makes this hormone in your gut after you eat. It does several important things. It signals your pancreas to release insulin, helping control blood sugar. It slows down how fast food moves through your stomach, so you feel full longer. And it communicates with your brain to reduce hunger signals. Pretty elegant system, right? The medications we're talking about, semaglutide, which is sold as Ozempic and Wegovy, and tirzepatide, sold as Mounjaro and Zepbound, they mimic this natural hormone, but they do it in a way that's far more powerful than what your body produces on its own. That's why patients tell me food just doesn't interest them anymore. They take a few bites of dinner and feel stuffed. Some say they actually forget to eat, which is wild if you've spent your whole life struggling with hunger and cravings. For weight loss purposes, the mechanism is effective. Less hunger equals less eating equals weight loss. Straightforward math. But here's where it gets complicated, especially for my older patients. When you drastically reduce food intake, you're not just cutting calories, you're cutting nutrients, protein, vitamins, minerals, everything your body needs to maintain muscle, bone, and overall health. Dr. Carolina Povian from Brigham and Women's Hospital explains this clearly. She says when you lose weight, you are decreasing caloric intake in terms of proteins, carbohydrates, and fats. The brain needs glucose. Fat by itself cannot be turned into glucose, and that is the major reason why muscle loss is inevitable when you decrease caloric intake. Let me translate that. Your body needs energy. When you're not eating enough, your body doesn't just burn fat for fuel, it also breaks down muscle. That's not a flaw in the medication. That's basic human physiology. For younger patients with plenty of muscle reserve, this might be acceptable. For a 70-year-old who's already losing muscle due to natural aging, it can be the difference between independence and dependence. The newer medications like tirzepatide actually target two hormones, both GLP-1 and GIP. This dual mechanism makes them even more potent for weight loss and blood sugar control. Some patients are losing 20–25% of their body weight. Historically, that kind of weight loss was only possible with bariatric surgery. Now you can get it from a weekly injection. That's remarkable. But remarkable doesn't mean risk-free. Let's talk about the gastrointestinal effects, because these matter more for older patients than people realize. These medications slow your entire digestive system. That's part of how they work. But that slowing can cause significant side effects. Nausea is extremely common. Research shows over 40% of patients experience it, especially when starting treatment or increasing doses. Vomiting, diarrhea, and constipation are also frequent complaints. For a 40-year-old, these side effects are annoying but manageable. You feel crummy for a few days, adjust, and move on. For a 75-year-old, these same side effects can become dangerous. Dr. Chitraganta, a geriatrician at Cleveland Clinic, presented a case at a medical conference that really stuck with me. An elderly patient with dementia was prescribed semaglutide. She developed severe dehydration, became delirious, and ended up hospitalized with electrolyte imbalances and acute kidney injury. Dr. Ganta explained that if we add the common side effects of GLP-1 medications, chiefly appetite suppression and weight loss, to conditions common in elderly patients, we increase the immediate risk of dehydration, delirium, electrolyte imbalance, and acute kidney injury. Now, that's an extreme case involving dementia, but it illustrates something important. Side effects that are merely uncomfortable for younger people can cascade into medical emergencies in older patients. Dehydration is particularly concerning. When you're nauseous, you don't want to eat or drink. If you're vomiting or have diarrhea, you're losing fluids. Older bodies don't compensate for fluid loss as efficiently. Kidneys work harder and recover slower. Dr. Nadaswaran notes that the risk for acute kidney injury in older adults is higher, because they tend to have other conditions like hypertension and chronic kidney disease that make them more vulnerable. Here's what I want you to understand from this section. These medications work by fundamentally altering your relationship with food and how your body processes it. That's powerful medicine. And while it can be incredibly beneficial, the very mechanisms that make these drugs work also create unique vulnerabilities in older bodies. Understanding this isn't meant to scare you. It's meant to prepare you for a smarter conversation with your healthcare team. Let's dive into something that really worries me as a physician. What happens to your muscles and bones when you lose weight rapidly on these medications? I mentioned earlier that aging naturally causes muscle loss. Between 60 and 70, most people lose around 10% of their muscle mass. After 70, it accelerates. This is called sarcopenia, and it's a major reason older adults become frail. An editorial in the Annals of Internal Medicine put it starkly. The authors wrote that natural aging reduces skeletal muscle mass by 12 to 16%. That leaves little margin before critical thresholds are crossed. Muscle loss from GLP-1 drugs could push some patients over the edge into frailty. Think about what that means. You might start these medications hoping to feel healthier, more mobile, more energetic. But if you lose too much muscle in the process, you could actually end up weaker and less capable of living independently. A 2024 JAMA study followed 195 adults through a year of treatment. They compared people doing exercise alone, people taking liraglutide alone, people doing both, and a placebo group. The results were telling. The group taking the GLP-1 medication without exercise experienced reduced bone mineral density at the hip and spine. But the group combining exercise with the medication, their bone density was preserved. That finding is huge. It tells us exercise isn't optional when taking these medications. It's essential, especially for older adults who already have compromised bone density. Now let's talk specifically about bones. When you lose weight rapidly, particularly more than 14% over 3 to 4 months, your bones take a hit. This happens with any rapid weight loss, whether from medications, surgery, or extreme dieting. Your body responds to weight loss by also losing bone mass. For older adults who may already have osteoporosis or osteopenia, this additional bone loss is concerning. Weak bones plus muscle loss equals a setup for falls and fractures. I've seen this play out in real life. A hip fracture at 70 or 80 can be devastating. Many patients never fully recover their previous level of function. Some don't survive the year following a hip fracture. Recent research found that tirzepatide, the dual-action medication sold as Mounjaro and Zepbound, was associated with a 44% higher risk of osteoporosis or fragility fracture compared to other GLP-1 medications. That data came from over 66,000 patients. But here's where it gets nuanced. Other studies, including a meta-analysis of 25 studies, found that GLP-1 medications were not significantly associated with increased fracture risk. Some research even showed improvements in bone density. So what explains these contradictory findings? The answer probably lies in individual factors. Your starting weight, your age, how fast you lose weight, whether you exercise, how much protein you eat, your baseline bone health. All of these play a role in how your bones respond. This is precisely why one-size-fits-all approaches don't work, especially for seniors. Dr. Viral Shah, an endocrinologist at Indiana University School of Medicine, emphasizes that people 65 and above are already at risk of sarcopenia. If those people lose even 10 to 15% of lean mass, it's still significant because they have low mass to begin with. Here's what I tell my older patients. If you use these medications, you need to be proactive about protecting your muscles and bones. That means eating enough protein. That means doing resistance exercise, not just walking. That means working closely with your healthcare team to monitor your body composition, not just your weight. The number on the scale doesn't tell you what kind of weight you're losing. You could be losing fat, which is great. Or you could be losing muscle and bone, which is not great. For seniors, that distinction matters enormously. I've had patients come to me thrilled about losing 30 pounds, only to discover through body composition testing that a significant portion was muscle. Their weight was down, but they were actually more frail than before. Weight loss in isolation isn't the goal. Health improvement is the goal. And sometimes those two things don't perfectly align. A 2025 study from Frontiers in Endocrinology, looking at elderly diabetic patients, did find that GLP-1 medications were associated with lower osteoporosis risk in that specific population. So for diabetics, the equation might be different. The research is still evolving, but the principle remains. Older adults need more careful monitoring and more supportive interventions when using these medications. I've spent a lot of time discussing risks, and I don't want you walking away thinking these medications are all downside. That's not true, and it wouldn't be fair to the science. Let me tell you about the benefits because they're real and significant. Heart health is where the data gets really impressive. A meta-analysis looking at cardiovascular outcomes in older adults found that GLP-1 medications reduced major adverse cardiovascular events by approximately 16%. We're talking about heart attacks, strokes, and death from cardiovascular causes. That's meaningful. Heart disease is the #1 killer of older adults. Anything that puts a real dent in that risk deserves serious attention. The Amplitude O trial showed that epaglenitide reduced cardiovascular events by 31% in older adults with type 2 diabetes. The SELECT trial found that semaglutide reduced these events by 23% even in people without diabetes who had obesity. Kidney protection is another significant benefit. The FLOW trial demonstrated roughly a 23% reduction in kidney-related events. Here's something that really caught my attention. A study published in late 2025 in the Journal of the American Geriatric Society looked specifically at patients 80 years and older with type 2 diabetes. That's a population many people would consider too old for aggressive new treatments. What did they find? Compared to another class of diabetes medications, the GLP-1 users had 14% lower risk of major cardiovascular events, 14% lower risk of major kidney events, 9% lower risk of hospitalization, and 18% lower risk of death from any cause. Those numbers in people over 80 are remarkable. Now let's discuss something even more intriguing: brain health. There's growing evidence that these medications might protect against cognitive decline and dementia. A Phase 2b clinical trial presented at the Alzheimer's Association International Conference found that liraglutide may protect brain tissue in people with mild Alzheimer's disease. Researchers reported it reduced cognitive decline by as much as 18% after 1 year. How does a diabetes and weight loss medication affect the brain? Researchers believe these drugs work through multiple pathways. They reduce inflammation throughout the body, including the brain. They improve insulin signaling, which affects brain function. They may even promote the growth of new brain cells. A review from 2025 noted that GLP-1 drugs reduce inflammation, improve insulin signaling, and promote neurogenesis, all of which could protect against cognitive decline. Large database studies have found that people taking GLP-1 medications develop dementia 40 to 70% less often than people on other diabetes medications. Now, these are observational studies, so they can't prove causation. But the pattern is consistent and worth investigating further. Major clinical trials called EVOKE and EVOKE Plus have been testing semaglutide in people with early Alzheimer's disease. While initial results didn't show benefits for people who already have the disease, the prevention question remains open and exciting. Let me give you more context on everyday benefits. For older adults struggling with obesity and diabetes, these medications can be genuinely transformative. Better blood sugar control means fewer diabetes complications. Weight loss can improve mobility, reduce joint pain, make stairs easier, make playing with grandchildren possible again. Dr. Ganta from Cleveland Clinic, despite her cautions about risks, acknowledges the upside. She says once these medications came out, they truly helped so many patients with metabolic disorders become healthier and improved their quality of life. She finds it satisfying to finally have something effective to offer patients who have struggled for years. That perspective matters. These aren't experimental drugs with questionable benefits. They're medications with robust evidence of real-world effectiveness. There's also emerging research on sleep apnea, fatty liver disease, and certain inflammatory conditions. Some researchers have even started calling GLP-1 medications the first longevity drugs because of their effects across multiple body systems. So here's the balanced picture I want you to have. These medications offer documented benefits that could be especially meaningful for older adults dealing with obesity, diabetes, heart disease risk, and possibly cognitive concerns. But those benefits don't come without trade-offs. And the trade-offs are more significant for older adults than for younger people. The question isn't whether these medications are good or bad. The question is whether they're right for your specific situation, given your health status, your goals, and your individual risk factors. Here's something that gets almost zero attention in popular coverage of these medications. Drug interactions. If you're over 65, you're probably taking multiple medications. The average older adult takes between 5 and 9 prescription drugs. Some of my patients take 15 or more. This is what we call polypharmacy, and it complicates everything. Dr. Matthew Schuster, a geriatrician at Hebrew Senior Life, points out that older adults take more medications than any other age group. Polypharmacy increases your risk of drug interactions and medication reactions significantly. Now, here's interesting news about GLP-1 medications. They don't interact with other drugs through the typical metabolic pathways. They're not processed by the same liver enzymes that handle most medications, so direct chemical interactions are relatively rare. But there's a catch. Remember how these medications slow stomach emptying? That affects how other medications get absorbed. When your stomach empties more slowly, Oral medications sit there longer before reaching your intestines where absorption happens. This changes how quickly drugs reach peak levels in your blood and sometimes affects how much you actually absorb. Let me walk through some specific examples. Levothyroxine for thyroid conditions is a big one. GLP-1 medications can increase absorption of thyroid medication by about 33%. That might sound minor, but levothyroxine has a narrow therapeutic window. The difference between an effective dose and a problematic dose isn't large. I've seen patients stable on thyroid medication for years suddenly develop symptoms of hyperthyroidism after starting a GLP-1 drug. Racing heart, anxiety, tremors, weight loss beyond what the GLP-1 should cause, all because they were effectively getting too much thyroid hormone. If you take warfarin or other blood thinners, there can be delays in absorption. Studies show the overall anticoagulation effect isn't dramatically changed, but more frequent monitoring of your INR is recommended when starting these medications. Blood pressure medications present an interesting consideration. As you lose weight, your blood pressure often drops naturally. Good news, right? But if you're already on blood pressure medication, your pressure might drop too low. That causes dizziness, lightheadedness, fainting, and falls. For older adults, falls are serious business. Diabetes medications require careful attention. If you're taking insulin or sulfonylureas alongside a GLP-1 medication, you could experience dangerously low blood sugar. Hypoglycemia in older adults can cause confusion, falls, and other serious complications. Here's what really concerns me in practice. Many older patients see multiple specialists who don't always communicate well. Your cardiologist prescribes something, your endocrinologist prescribes something else, your primary care adds another. Without careful coordination, medications can interact in ways nobody anticipated. Dr. Schuster emphasizes involving your primary care provider in decisions about GLP-1 medications. They may be the only physician who sees your complete medication picture. There's another factor many people don't consider. Weight-related dosing adjustments. Many medications are dosed based on body weight. When you lose 20 or 25% of your body weight, medications that were appropriate before might become too strong. This is particularly true for fat-soluble medications that distribute into fatty tissue. As you lose fat, these drugs have less tissue to distribute into, effectively increasing their concentration. Suddenly, your usual dose might be too much. Thyroid medications, some psychiatric medications, some heart medications, all of these might need adjustment as your weight changes. This isn't a one-time consideration. Throughout your weight loss journey, ongoing medication reviews are essential. A pharmacist can be invaluable here. Many pharmacies offer medication therapy management services where a pharmacist reviews your entire medication list for interactions and problems. If you're considering a GLP-1 medication and you take multiple prescriptions, I strongly encourage you to take advantage of this service. When you start a GLP-1 medication, don't assume everything else stays the same. Pay close attention to how you feel. Report any new or unusual symptoms. Expect that some of your other medications will probably need adjustments. I've had patients tell me they feel different but couldn't explain how. Sometimes it's the GLP-1 medication itself. Sometimes it's another medication now acting differently because of weight changes or absorption changes. Teasing apart these effects requires careful attention and open communication with your healthcare team. This isn't meant to discourage you from these medications. It's meant to help you approach them with appropriate attention and coordination. The benefits can be substantial, but realizing those benefits safely requires more careful management in older adults than in younger patients. All right, let's get practical. If you and your doctor decide a GLP-1 medication makes sense for you, what can you do to maximize benefits and minimize risks? Two things matter more than anything else: protein and exercise. I'm not exaggerating when I say these are not optional. For older adults on these medications, they're essential. Let's start with protein. Research from Massachusetts General Hospital shows that combining high-protein diet with consistent exercise during GLP-1 treatment provides the greatest benefit for preserving bone and muscle mass. When you're on these medications, your appetite drops dramatically. You're eating less overall. If you're not intentional about protein, you might get half of what you actually need. How much protein are we talking about? For muscle preservation during weight loss, experts recommend 1.2 to 1.6 grams of protein per kilogram of body weight daily. Let me translate that into practical terms. If you weigh 160 pounds, that's roughly 73 kilograms. At 1.2 grams per kilogram, you need about 87 grams of protein daily. At 1.6 grams per kilogram, you need about 117 grams. What does that look like in food? A chicken breast has about 30 grams of protein, Greek yogurt, about 17 grams per cup. 3 eggs give you roughly 18 grams. A can of tuna provides about 20 grams. A cup of cottage cheese has around 25 grams. To hit 90 to 110 grams daily, you need protein at every single meal plus high-protein snacks between meals. A joint advisory from multiple medical organizations recommends 80 to 120 grams of protein daily for people on these medications. They also emphasize spreading protein throughout the day rather than loading up at dinner. Here's why timing matters. Your body can only use so much protein at once for muscle building. Research suggests 20 to 30 grams per meal is optimal for stimulating muscle protein synthesis. Eating 90 grams at dinner and skipping breakfast protein is far less effective than spreading it across 3 meals and snacks. For patients with suppressed appetite, this is challenging. Smaller, frequent meals often work better than 3 big ones. Protein shakes and smoothies go down easier than solid food when you're not hungry. I tell my patients to prioritize protein first at every meal. Eat the chicken before the rice. Have the eggs before the toast. When you can only eat a little, make sure what you eat counts. Now let's talk about exercise, specifically resistance training. Walking is wonderful. I encourage all my patients to walk. But for preserving muscle during weight loss, resistance training is in an entirely different category. Medical research consistently shows that resistance exercise is the most powerful tool for maintaining lean tissue during weight loss. Even modest strength training twice weekly produces significant benefits. That JAMA study I mentioned earlier found that combining GLP-1 treatment with exercise preserved bone mineral density at the hip, spine, and forearm. GLP-1 treatment alone decreased bone density. Exercise made the critical difference. What kind of resistance training? You don't need to join a gym or hire an expensive trainer. Focus on compound movements that work multiple muscle groups. Squats work your legs and core. If regular squats are too hard, hold onto a chair and do assisted squats. Wall push-ups or counter push-ups work your chest, shoulders, and arms. Seated rows with a resistance band work your back. Simple bridges lying on your back work your core and glutes. Aim for 2 to 3 sessions weekly with rest days between. Start with easier versions and progress as you get stronger. Consistency trumps intensity. Regular moderate sessions preserve more muscle than occasional hard workouts. If you've never done strength training, consider a few sessions with a physical therapist who works with older adults. They can teach proper form and create a safe starting program. Timing protein around exercise enhances results. Research suggests eating 20 to 30 grams of protein within an hour or two after resistance training maximizes muscle preservation. Researchers at Mass General Brigham note that patients who exercise regularly from the start of treatment and throughout have the best outcomes for preserving lean mass while losing fat. Here's the bottom line. Taking a GLP-1 medication without addressing protein and exercise is like getting a fancy new car and never changing the oil. You might get somewhere, but you're setting yourself up for problems. Combine the medication with adequate protein and regular strength training, and you shift the equation dramatically. You lose more fat, preserve more muscle, and come out stronger rather than frailer. For older adults, that difference could determine whether you emerge from weight loss more capable and independent or weaker and more vulnerable. Let's discuss something critically important: recognizing when something is wrong and when to seek medical attention. Every medication has side effects. Some are normal and expected. Others signal something more serious. The common side effects that usually aren't dangerous include nausea, which affects up to half of patients starting treatment. It's typically worse during the first few weeks and when doses increase. Most people find it gradually improves. Other common issues include vomiting, diarrhea, constipation, and abdominal discomfort. These relate to how the medication slows your digestive system. To manage these common effects, eat smaller meals more frequently. Avoid greasy, fatty, or spicy foods, especially early in treatment. Eat slowly and stop when you start feeling satisfied. Stay hydrated by sipping water throughout the day. When nauseous, stick with bland foods like crackers or plain rice. These side effects usually improve over time, but there's a crucial difference between discomfort and danger. Here are the warning signs requiring immediate medical attention. Severe abdominal pain that won't go away could indicate pancreatitis, inflammation of the pancreas. This is rare but serious. If you have persistent severe stomach pain, especially if it radiates to your back and comes with vomiting, get medical care immediately. Signs of severe dehydration are critical, especially for older adults. Watch for dizziness or lightheadedness when standing, extreme thirst, very dark urine or barely urinating, confusion or unusual mental changes, and rapid heartbeat. Dehydration can lead to electrolyte imbalances and acute kidney injury. If you're vomiting repeatedly, have severe diarrhea, or can't keep fluids down, don't wait. Get help. Severe constipation or possible bowel obstruction needs attention. If you haven't had a bowel movement in several days and have significant bloating, pain, or vomiting, this could indicate gastroparesis, severely delayed stomach emptying, or even bowel obstruction. Both require evaluation. Low blood sugar signs matter, especially if you take insulin or certain other diabetes medications. Symptoms include shakiness, sweating, confusion, irritability, rapid heartbeat, and feeling faint. Severe hypoglycemia is dangerous and needs immediate treatment. Allergic reactions, while uncommon, require emergency care. Seek help immediately for difficulty breathing, severe rash or hives, and swelling of face, lips, tongue, or throat. Vision changes should be reported promptly. There's limited data suggesting possible links to eye issues, including worsening diabetic retinopathy. If you notice vision changes, especially if you have diabetes, contact both your eye doctor and prescribing physician. Mood or thinking changes are worth discussing with your healthcare team. While these medications haven't been definitively linked to mental health issues, significant changes in how you feel emotionally or cognitively should be evaluated. Unexpected weakness or decreased ability to do activities you could do before might signal accelerated muscle loss. Bring this up with your doctor. There's an important consideration about surgeries and procedures. Because GLP-1 medications slow stomach emptying, there's concern about food remaining in your stomach when you need anesthesia. If you're scheduled for any surgery or procedure requiring general anesthesia or sedation, tell the medical team you take a GLP-1 medication. Current recommendations often suggest stopping the medication several days to a week before planned procedures. This ensures your stomach is properly empty, reducing aspiration risk during anesthesia. Don't skip this conversation. Aspiration, where stomach contents enter your lungs during anesthesia, is a serious complication that's preventable with proper planning. A word about stopping these medications. If you need to stop for any reason, discuss how to do it safely with your doctor. Stopping abruptly often leads to rapid weight regain. Research suggests this regained weight may preferentially be fat rather than muscle, potentially leaving you in worse body composition than when you started. Studies show up to 2/3 of people discontinue these medications within a year, often due to cost or side effects. If stopping becomes necessary, having a plan for maintaining your progress is important. The key message here is staying connected with your healthcare team. Report concerning symptoms promptly. Ask questions when something doesn't feel right. Don't hesitate to seek emergency care when something feels seriously wrong. I always tell my patients that they know their bodies better than anyone. If something feels off, speak up. Early intervention for problems is always better than waiting until things get worse. We've covered a lot of ground together. Let me try to pull it all together for you. GLP-1 medications represent a genuine breakthrough. The data on cardiovascular protection, kidney benefits, blood sugar control, and emerging brain health possibilities is compelling. These are not gimmicks or fads. They're medications with real evidence behind them. At the same time, they carry specific risks for older adults that don't get adequate attention. Muscle loss, bone density changes, dehydration risks, drug interactions, all require more careful consideration when you're over 65. So how do you make a decision? First, have an honest conversation with your doctor about your actual goals. Are you trying to improve diabetes control, reduce heart disease risk, improve mobility, lose weight for a specific health reason? Understanding your goals helps determine if these medications align with what you're trying to accomplish. Second, get a comprehensive health assessment. What's your current muscle mass, your bone density, your kidney function, your complete medication list? The more your doctor knows about your starting point, the better they can predict how you'll respond. Third, understand that age alone doesn't disqualify you. The principle in geriatric medicine is start low and go slow. Experts note that intermediate doses may work well for older or frailer patients without pushing to maximum doses. You don't necessarily need the highest dose if a lower dose works for you. Fourth, commit to the full package. If you try these medications, also commit to adequate protein and regular resistance exercise. The research clearly shows these supportive measures dramatically improve outcomes. Taking the medication without addressing diet and exercise is a setup for problems. Fifth, plan for ongoing monitoring. This isn't take it and forget it medicine. Regular check-ins with your healthcare team, watching your weight loss rate, monitoring for side effects, adjusting other medications as needed. All of this is part of responsible treatment. Sixth, consider the financial reality. These medications are expensive, often exceeding $1,000 monthly without insurance. Coverage has been expanding for diabetes, but coverage for obesity alone remains limited. Don't let cost pressure push you toward unregulated sources or questionable compounding pharmacies. Seventh, be realistic about duration. These medications work best as long-term therapy. If you stop, weight typically returns. You're potentially committing to years of treatment. That's a significant consideration. Let me share what researchers emphasize. Experts write that these robust medications can and should be prescribed to the appropriate patient. That's the premise of precision medicine. However, they note we need additional data on long-term safety in older adults. They stress that the foundation for prescribing should be a comprehensive lifestyle program, including diet and exercise. These medications should supplement, not replace, healthy behaviors. That's the core message. These are tools, not magic solutions. They work best as part of a comprehensive approach, including nutrition, exercise, and close medical supervision. For some older adults, GLP-1 medications will be life-changing in the best way. Better blood sugar, reduced heart risk, improved mobility, potentially cognitive protection. For others, the risks may outweigh benefits. Significant muscle loss, fractures from weakened bones, dangerous dehydration, medication interactions could do more harm than good. The only way to know which category you fall into is thorough, individualized discussion with healthcare providers who know your complete history and can monitor you carefully. I hope this video has given you the information you need for that conversation. You now have questions to ask and topics to raise. Here's what I want you to remember above everything else. Your health decisions are personal. What works for your neighbor, your friend, or someone you saw online might not work for you. Take time to understand your options, ask hard questions, make choices based on your individual situation. If you and your doctor decide to try these medications, go in with eyes open. Prioritize protein. Do the strength training. Stay connected with your healthcare team. Watch for warning signs. And if you decide they're not right for you, that's a perfectly valid choice too. There are other paths to better health. Whatever you decide, I want you making that decision from a place of knowledge, not from hype or fear. Thank you for spending this time with me today. If you found this helpful, please share it with others who might benefit. And drop your questions or experiences in the comments. I read them and they help me understand what topics to cover next. Take care of yourselves. I'll see you in the next video. This is Dr. L. Owen. Stay healthy, stay informed, and stay in charge of your own health decisions.